Okay, sir. First is team 1. Team 1, are you ready, right? You have 2 PGs, Harika and Radha Manjusha from Gandhi Medical College. Team 1, your first spotter. Bhattacharya sir and AK Singh sir, please lead the questions.
Hello.
Professor AK Singh, you may start, please. Professor AK Singh?
I was muted, so no, I was muted. Fine enough. So
Okay.
the participants are going to say something about the patient. With then we follow that.
Okay,
Yeah.
I will tell. This is an incidence of blast injury in a temple where large number of people were affected by burns, and there were mass casualties, and burns of different categories, different age groups, different sex, they were involved in that blast, and it not only caused flame burn, but blast injury itself has a complicated burn area, plus electrical injuries happened because of the blast. There was short circuits, so there was a mass casualty, and it was in a common place, public place, this burn happened.
Okay. So question to team: how would you triage these patients? As you said, there are 45 patients who are burnt. How would you triage them?
Sir, we need to triage them into 4 categories. The first category would be a smaller percentage of burns who does not require immediate emergent management. And the second category would be the patients who would be needing minimal management, like some oxygen inhalation or support through which they can be stabilized. And the other team and the third group would be having some life-threatening injuries, which might involve inhalational burns or ongoing fire on them. And the fourth category would be the moribund or already dead patients, or the patients who are having more than 80 to 90% of the burns.
So based on the triage, how will you manage these patients?
Sir, first we need to focus on the second and third groups, because the first group usually have a smaller percentage of burns and superficial burns, whereas the group 2 and group 3 would be needing expectant management from us. So we need to stabilize the patients with that. And in the group 3 who have life-threatening injuries, we need to focus on them doing the needed investigations and starting the resuscitation as early as possible. And on the site of triage, if you are a single person, we need to take help from the other personnel. We need to stop the ongoing process of the thermal or the electrical burns, whatever is happening, taking care that the rescuer does not get affected themselves. And we need to shift the patient, start the resuscitation and shift the patients as early as possible to a nearby burns unit.
Okay. Is this photograph visible to you properly?
Yes, sir. I can see 2 patients in this photograph.
One is pediatrics, sir.
Okay. The patient who's further from the screen, I think the clarity is not there, so we'll omit that patient. But we'll take the patient who is nearer and in the white sort of a loincloth or white drape around that patient. Okay. So what are the injuries do you see on this patient?
Patient is having almost mixed thermal burns, sir, involving entire trunk, face, upper limbs and lower limbs.
Inhalational burn. Probably presence of inhalational burns as well, which we are not able to clearly make out because we are not able to see the face and anything else. But there is probably oxygen inhalation being provided.
Okay.
And we are not
Because
even
they're
able to see the posterior surface, so we cannot accurately tell the percentage of burns. But looks like almost the
Okay.
whole body is involved, and we are not able to see the perineum as well, so can't comment on it.
Okay. Suppose, those areas which are hidden and we are not able to see them, perhaps they are not burned. Let us take it that way. They are not burned. So what would
Okay.
be your immediate priority of management for this patient?
Sir, we need to the same protocol ABC. First, we need to check regarding the airway, breathing, and regarding the circulation. So we would first try to see whether the patient is conscious, and we would like to talk to him. If he is able to respond in words, that means that his airway is okay. Then we would start immediate resuscitation to him. Before we calculate the total percentage, we can immediately start the resuscitation at the rate of 10 to 20 ml per kg per hour before we calculate the exact percentage and go for the further resuscitation. And it looks like his chest and probably the face is also involved. There is a high probability of inhalational burns because there is a history of blast injury. So we need to start immediate oxygen inhalation, and we need to send the samples for ABG analysis and other routine parameters.
Okay. How would you calculate the fluid which is to be administered to this patient?
As per Lunden-Browder chart, as he looks like a child.
Yeah. That Browder chart is for basically for thermal injuries or for explosive injuries or
It's usually for thermal injuries, sir.
Okay. So the first thing which you said, you will try to see to the airway and secure the airway. How would you further investigate whether what would be the symptoms that the lower airway is also involved? The respiratory tract is involved. Clinical
Presence of any
symptoms.
Particles, sir.
Pardon?
Sir, inhalational burns we can identify by looking at the presence of any singed hair, soot in burns around the nose, mouth, on the neck, presence of any soot particles in the oral cavity or around the nose, and any expectoration of any carbonaceous sputum and edema of
laryngeal edema.
But how would you see laryngeal edema?
Presence of any V's or a stridor which we can identify clinically.
Okay. If you find that the respiratory tract or you find certain things which are positive amongst this, how would you manage the airway part of it?
Sir, first thing is immediately
oxygenation should be given, sir. Immediately with 100% of oxygenation should be given.
Propped position.
By?
Sir?
100% oxygen by what? How? How would you give 100% oxygen? Are we still online?
Yes, sir. Yes, sir.
With what method would you administer 100% oxygen to the patient?
Bag and mask.
The bag and mask ventilation, you feel that you can provide 100% oxygen, you can put the mask on the face of the patient, and which is
by non-invasive method, you can provide 100% of oxygen.
Pardon, sorry?
By non-invasive.
Sir, can we answer, sir?
Yes, goes to team 2.
Sir, elective intubation of the patient followed by administration of 100% oxygen.
Sir,
what would be the role of a tracheostomy in such a patient?
Sir,
what would be the opinion?
So these days, after the advances in the I mean, mouthpieces and the kind of ventilation we are getting, tracheostomy is usually not initially performed in the cases unless there is
Agreed.
severe respiratory obstruction. So we need to go expectantly, but tracheostomy or such an early intubation is not usually indicated these days, unless and until we see that there is severe respiratory obstruction. When the patient is going into acidosis or ventilatory arrest. So in our setup, we have seen initial support being provided with a bag and mask ventilation only, sir.
Okay. Fine enough. How would you rule out, with these sort of injuries, whether the patient has got, additional damage or damage by other gases? I hope you'll understand which gas.
Sir, arterial blood gas analysis, we can check for the presence of any carboxyhemoglobin or any methemoglobin.
Coaximeter can also be.
Coaximeter can also be used. So based on that, we can understand. And usually in any closed space explosion injuries, there are high chances of carbon monoxide poisoning.
Okay, fine. What would be your next step after that?
Sir, once we start the resuscitation and try and stabilize the patient, we would give other supports, like we would continue with nebulization for the patient also. And serially, we would be monitoring the patient to see that the child has adequate urine output and the resuscitation is adequate. And immediately in the first 24 hours, we might not find any significant changes regarding the inhalational injury in the chest X-ray. So we would be continuing ABG monitoring every 6th hourly to see that the oxygen support and the respiratory support which we are giving is adequate. If we find that it is not adequate and the child is or the patient is going into worsening, then we need to think regarding the research. Regarding the further things like tracheostomy or planned intubation in such conditions. If a child is stable, we would continue with the resuscitation and the support, and we would be adding nebulizers and start prophylactic antibiotics. And if there is circumferential burns over the chest, we would plan for eschorotomy incisions over the chest wall.
So you are in charge of the burn care in a hospital, and the superintendent gives you a call that there is a blast injury with mass casualty. Within 1 hour, the victims are arriving. So what will be your methodology to take care of such mass casualty in your hospital? What are the things you will think of and arrange?
So first, regarding the arrangement of the personnel and regarding the arrangement of the equipment and the beds
No,
needed for the management.
don't give vague answers. Personnel, equipments, not like that. Which
Yes,
are
sir.
the areas? Yeah.
Sir, I would immediately alert the emergency room and the burns ward, and would arrange a temporary burns unit just next to the emergency ward, not to overload the emergency ward continuously, and so that we can stabilize, we can shift the stabilized patients to the burns unit immediately, and we would alert all the. We would arrange for necessary equipment for the oxygenation, resuscitation, and the monitoring, and lab to get the necessary investigations done.
Team B?
And we would be needing we would have to involve the blood bank also. We would be needing blood because it's a mass casualty. Apart from burns, there could be other injuries as well. So we would inform and be alert with the other teams as well, like the trauma unit and the ortho unit. And we would inform the blood bank, and we would be arranging the blood products also as well in advance. And we
Good.
would keep the emergency operation theater ready if we need to operate on any patients in an emergency, not just burns, for the other things. And regarding burns, if we have to do immediate fasciotomies and all that, it would be easier for us if we have it ready.
Sir, we have to inform the anesthesia team also for elective intubations, and we have to inform the OT staff also, sir, and we have to look for the nearby other hospitals where the burn care can be taken, so that the load will be shared with the other hospitals.
Yes.
And we have to make sure the IV fluids and all is arranged, and cannulas and all. We have to talk with the administrative staff, and we have to make sure the arrangement for done for all resuscitation materials, sir.
Yes.
Yeah, that was all.
So combined, both the teams have answered most of the thing. Okay. So naturally, you have to segregate the patient, identify the patients according to the intensity of injury, then OT, ICU, ward, airway maintenance. Of course, you have to talk to the anesthetist, and most importantly, the medicines. Because the patients' attendants are not there, it's an accident. The administration has bought those patients, so you have to manage all the medicines immediately. So this
Yes, sir.
encompasses the whole management, and of course the additional centers which you have mentioned. Okay, so
So
when
time.
you okay, fine, it's time now. Next,
Next
Boss.
remarks
Yeah.
by the model. Bajaj sir.
Moderate.
All right. First of all, very good result answers you have given. But tell me one thing: have you seen this patient correctly?
Sir,
Sir,
Have you seen this patient correctly?
sir, only on the photograph.
Sir,
the
can we
photo.
answer, sir?
Now, what are the you said that you are going to segregate these patients, class 1, 2, 3, 4. In which class this patient falls?
Sir,
In which category
third.
this patient falls?
Third grade, in which she has inhalational injuries as well.
All right, that you can't see at the moment. You have gone,
Yes,
you have
sir.
seen this patient.
Sir, she will fall into fourth, sir, because she was
Sorry?
having 100%. She will fall into fourth, sir.
Fourth category. What you do with fourth category patients? You have got 45 patients coming to you. This fourth category of patient, which is not going to make it, whatever you do it. And you are spending all your time in doing arterial gases and all these cases. This patient appears to be 100% burned, along with respiratory burns. And that you have got patients, you have 45 patients. And if you start doing on this, you will be spending more than 3 to 4 hours on this patient, the result of which will be 0. And in that case, you will be losing some attention to other patients. Am I right?
Yes, sir.
So therefore, you have failed in properly categorizing this patient. Second thing, you failed in seeing where I should put my attention to which group of patient. First thing you said is you will take down the patient which are likely to make with your help, which fall in the category of second and third. Why do you put down so much work on this patient? So this patient has to be kept calmly, coolly, without pain and other things. That's it. So therefore, your management part becomes completely wrong. For a patient where 45 patients occur, 45 patients are burns, you have to think over what patients you can make it. Is it clear?
Yes, sir.
Now, seeing it, what is the depth of the burns, whatever the group you are seeing it? On looking at it, what do you think the depth of burns?
So looks like deep partial to full thickness burns.
Is it deep partial?
Sir, it looks like
over
degree
the
deep
trunk,
burns,
Over
sir.
the
over
trunk
the
or-
trunk, sir.
It is
On
our
what-
chance, please.
On what basis you are saying it's a deep partial?
Sir, some areas, most of the areas looks like full thickness burns.
All right. So full
It looks
thickness
like
burn.
third degree burn, sir, because on the chest we can see scar also, sir. Scar and trauma.
I told you first thing, what Dr. Bhattacharya gave the history, that it is a mass casualty with 45 burns patients coming to you. So you have to separate it out where I should put down or hold my team, put attention to. So you have failed in segregating this patient. Trials was not right from you.
What he is telling is the prioritization. How do you prioritize these patients when you get a mass casualty? You have to
Yes, sir.
segmentalize these patients.
We could not see the posterior side.
Now let me put down on the basis of percentage chart, what is the probability of this patient to survive in the best conditions of the world?
Chances of survival is very less for this pediatric patient, sir.
I am just asking you. You know what Bull's chart and other chart which gives the probability of survival? Have you listened to the Bull's chart? American Burns Units chart, which gives probability of survival.
Stop it.
Now you see the patient have full thickness burns on the face, both arm, upper limb and lower limb, and on the chest. So therefore, practically speaking, we can say these burns are definitely more than 95% burns. In the best condition of the world, what is the chance of survival of a 95% burn? Have you heard of Bull's chart?
No,
No,
sir.
sir.
Team 2.
Almost nil, sir. Very low chance. This case.
He is asking Bull's chart.
All right. At the moment in the world, what is the LD50 for burns patient? Best condition of the world.
Sir,
In the best conditions of the world, what is the LD50 for this age group patient?
in the best condition.
All right. Forget, leave the word LD. What are the chances at the moment in world? How much percentage of burns can be saved? Best condition of the world.
Sorry, 80%.
All right. Is this burn 80%?
No, sir, more than 80%.
Therefore, the chance of survival in the best condition of world is nil. And therefore, you are putting down all your energy in saving this patient. And the rest of the 45 patients, who will look after? What the best treatment for these patients in your scenario? Tender,
Just
loving
supportive
care.
treatment and focus on the other patients.
Yeah, that is the answer. By focusing so much on this, you are just wasting the energy and the time and the resources which you have got at your disposal. Now, team 2. What do you think about the on the chest? What is happening to the patient on the chest?
Chest patient
Burns
had
on the-
scar, sir. So
How is the burn from the chest?
chest he had scar. Child has scar, sir. So if patient had breathing difficulty, we have to do scarotomy, sir.
Even if suppose at the moment patient is not having breathing difficulty, and burns are only on the chest, forget about rest of the burns. Be comfortable, think for a minute, and then answer.
Sir,
That's all done. చెప్పు పర్లేదు.
Team 1.
so can we get the question again, sir? Audio is not clear, sorry.
What if on the burns you have got the chest burns? What do you think? What you will do for this chest burns? Or what is happening to the
Suppose
patient?
the patient is having only chest burn and no other burn, then what do you do? This is what sir wants.
We can go with early excision and grafting, sir.
After stabilizing the patient.
The question asked, listen to me. Spend a minute before you answer. You are seeing the burns on the chest? Why I'm specifically asking. Now, these burns on the chest, what it will lead to? And what these burns are causing the problem?
Circumferential compression causing breathing difficulty. So we need to do an
circumferential. Even it is not circumferential. Full thickness burn anteriorly only.
Even then it would cause difficulty in the chest expansion. So we would have to go for eschorotomy incision.
That is the one. That's the life-saving thing required before you go for anything else.
Yes.
Okay, that's you given the answer. Correct. All right, I think we should finish it.
Any questions from other faculty or judges?
Can I speak, sir? Can I speak?
Yes, sir.
Yes, sir.
Okay. Good afternoon to all. What Dr. Bhattacharya has asked, in fact, in mass burns, I have the opportunity of handling about 4 or 5 issues. Most important today's world is the International Burn Society. They have a ISBI, the burn injuries, International Society for Burn Injuries. They have a trial system. And in the trial system, mild, moderate, and severe burns have been identified and categorized at the spot, site-wide occurrence. And nowadays, the paradigm of change in the, not in the percentage, but mostly on the inhalation and respiratory burns. So we had a case in Calcutta, 90 patients died in a Amri hospital, where 70% were having the respiratory and inhalation burns. So here the prioritization and trial system, you have to keep up the different colors are also there. So you have to put on different categories of patients, and the communication system will be made accordingly to the prioritizing patients, so that at least within 4 to 5 hours, if the respiratory burn patient has to be intubated, or the other option is always there is doing a tracheostomy. So one should be very much leisure, in fact, by the intensive care unit, which we are having one. We have seen most of the cases, we could make to survive within some couple of hours, that 5 to 6 hours. So that trial system, I think, has to be developed in most of the centers. And that is as per the guidelines of the International Society for Burn Injury, ISBI. So there is a system in that. And
Dr.
in our...
Dr. Venkatratnam, would you like to comment anything?
I mean, same thing I wanted to tell. One thing sir was telling, same thing I want to emphasize on triage. And now the sir mentioned about the color cards also. So that team is separate from the medical team. As a medical person from your side, for the administrative purposes, the triage is very important. You have to do the triage, identify and give the cards. Those cards will stay with the patient for throughout the hospital stay. At least they will be useful on the first day to which floor, to which department, ICU or operation theater or outpatient. That differentiation depends upon the color. So everybody will take care of their duties once you do the proper triage. That's what I want to emphasize. Thank you.
Okay, sir. If you allow me, can we move to the second spotter, sir?
Move to the second spotter.
Spotter 2, I would like to request Dr. V.K. Tiwari, sir, and Sundar Raj, sir, to lead the questions.
Dr. Tiwari, please.
Hello, am I audible?
Yes, yes. Yes.
The questions there for team 1 or team 2?
Team 1, sir.
Team 1.
Yeah. Have you seen the case, team 1?
Pictures.
Yes, sir.
Can you see the...
Sir?
In the pictures.
Just tell about the diagnosis of the patient.
Describe.
Sir, we can see a post-burn sequelae over the face, involving the right cheek, lower lip, and neck, causing post-burn contracture of the neck of grade 3, grade 4,
Grade 4.
with lower lip ectropion.
And
Mentosternal adhesions with lower lip ectropion, sir.
what could have been the functional problem in this patient?
With limitation in the neck movements, especially the neck extension, and feeding difficulty because the lower lip is also everted.
Yeah. And what about vision?
Eyes that
there is no neck extension properly, so there is loss of upward gaze, and in other pictures the eyes are
So what are your plans for this case?
Sir?
Grade 4 contraction neck. What are your plans? How you will manage this case?
Sir,
it is going to be anesthesia problem. Do you know Mallampatti classification? What is that? Mallampatti classification?
Before there will be difficulty in intubation, sir.
What is Mallampatti classification?
Mallampatti classification, that is
score rather, not it is
Mallampatti classification.
Score.
Admitting fingers based on the
for anesthetists, not for surgeons, but still we should know it.
Sir, can we answer, sir?
Based on sir, it has 4 classes, sir. We can based on the visualization of in the grade 1 we'll have a complete visualization of the soft palate. In 2 only the we can see the uvula, and in grade only the base of the uvula can be seen, and grade 4 the soft palate is also not visible.
Okay. But how you say anesthetist is new there? You are going to operate this patient. What are your plans, by the way? What you are planning for this patient?
In this, we can do incisional release and excisional
So first we would evaluate the patient, I mean, do the pre-anesthetic checkup and other preparation for the surgery. We would get an X-ray of the neck to see the tracheal positioning. And we would look at the donor sites to see if there is, I mean, if she was operated prior for any other ones, because here we can see only the neck. And based on her other history, once we are posting her for the surgery, we would inform the anesthesia team beforehand so that they can arrange for a fiber optic intubation. If they're unable to do the awake fiber optic intubation, then we would have to give tumescent anesthesia over the neck contracture and release the contracture so that the Mallampatti grade can be improved and they will have neck extension by which they can intubate the patient.
How you will calculate the amount of defect? Say preoperatively to calculate the amount of skin. You are planning to put the skin graft or flap?
Yes, sir.
Graft.
Skin. Yes, sir.
So how you will
need to calculate
rough calculation of amount of graft, or how you will know the amount of defect? How you will calculate that?
Sir, we need to calculate the defect by comparing it with another normal individual of the same height and personality by marking from the bony prominences, and we would get an apparent defect. So based on that, we can calculate the defect size in her post the release of the contracture.
So while releasing the contracture, what you expect that what is going to be the depth of your release? Depth of your release, up to which structure you are going to release this?
Up to the platysma, sir.
You are be releasing platysma, or you will be sparing platysma?
Sir, we will have to release the platysma also, sir.
Yeah. Without that, you won't be able to get released.
Able to get the full extra.
Then how you will fix the graft?
Sir, first we should not take a straight line incision. We need to take some fishtailing at the edges or do a darting so that we don't have a linear scar to avoid any recurrent contractures in the
Then
future.
you do fish. At which part you do fish tailing?
End, sir.
Then
We need to release up till both the neutral lines, completely expanding the defect. And then we need to put an unmeshed split to medium thickness graft and fix it over the corners and give a bolster dressing.
It should be placed horizontally over the neck.
how you will fix those grafts? Suppose you have taken a graft, how you will put them, vertically or horizontally?
Horizontally, sir.
Why? Why not vertically?
Sir, it would cause a linear contracture again if we are placing it vertically. There is chance of recurrent contracture.
What is quilting? Graft
Sir,
quilting?
quilting is fixing the graft to the graft bed, wound bed.
In the neck, which area is the most vulnerable area for graft rejection, or in which graft is difficult to take?
Team
Sir,
2?
Team 2?
Sir, over the fatty part under in case of
Anatomical
the thyroid
area.
patient.
Which
Over the
anatomical
thyroid,
area?
central part. Over the thyroid.
Yeah, what is that known as?
Adam's apple.
Adam's apple. Yeah, that is why it is the usually graft rejection is there in that area.
It moves up during deglutition.
So
the graft constant. So we need to fix it,
basically,
sir.
even if you put a rice tube saliva, you are going to
Yes,
take
sir.
inside.
So there is chance.
There's going to be always movement of that. And what about post-op care?
Sir, intraoperatively itself, we will put a rice tube for the post-op nutrition of the child, or nutrition of the patient, and we would give a bolster dressing, and we would ensure that the patient lies with the neck in extension position. Pillow is avoided, and we would keep a folded towel below the shoulder blades to ensure that the neck is in extension. And in our center, we usually do the primary dressing on the 5th post-operative day.
Why?
If there is no soakage or any other
Why you do on 5th?
or any discharge.
Why
Sir?
you do on 5th day? In
Sir?
plastic surgery, in surgical case, why you do dressing on 5th day? Why not on 7th or 10th day? What is the reason for doing this dressing on 5th day?
So 5th to 7th day we do, sir, but usually we do it on 5th day to just check, sir. That's what has been followed in our institute.
Say if you have opened the dressing on 5th day and there is a small hematoma underneath the graft, seroma underneath the graft, what you will do? What is the or in other way, what is the advantage of doing dressing on 5th day?
Sir, that's what, sir. We do to see if there is any collections, and we can just give a pinprick and drain out let the collection drain.
Then
Then we would
what you will do after that?
We would give a dressing again. Keep
You
the
will
neck in
put
extension.
put that graft back, or you do something else also. You have drained the seroma, then what you will do? You will put the graft, put that area back, or you do something before putting the area back. Putting that elevated graft back, you will do something else, or you will just drain the seroma and put it back.
So we drain the seroma. If we have any excess graft, we would place it and put a dressing over it. Sir.
Team 2?
Sir, we have to remove any clots is there below the graft, sir.
You have removed it. You have removed. You have drained the seroma.
And we have to scrape, sir. We have to scrape the graft side, sir. Yeah.
Where you have to scrap?
Graft side, sir. The graft, the skin graft side, or the dermal
Bad
side.
or undersurface of the graft?
Yes, sir.
Undersurface.
You have to scrape the undersurface of the flap, because by that time epithelialization that occurs, within 2 days epithelialization that occurs. Otherwise, graft is not going to take. Then,
because there was collection.
what about the other post-operative that thing, rehabilitation?
Sir, I'm sorry.
How long you will continue with this splintage?
So we would start the splintage when the graft settles, and we have to continue it till at least for 1 year, sir. For the first 6 months, it is continuously worn for 23 hours a day. And after 6 months, we can use night splintage after 6 months till the end of first year.
Yeah. Okay,
Dr. Sundar Raje, you want to ask something?
Yes, sir. We discussed about true and apparent defect. Are you aware of any published method to accurately measure the true
defect size?
From the bony prominences like mentum,
Name the
acromion process.
Name the
Sir?
published method. It is from India.
Yes, sir.
Organizers are there, authors of the method. Team 2.
You may answer if they can't answer.
ARC method published in 2021 by Sujata Sarabhai Madam. Rohit is also an author there.
Yes, sir.
Yeah. Any pros and cons with skin grafting and flaps after you release?
Sir, with grafting, flap would be needed if we have exposed any vital structures. But it is usually bulky, and appearance-wise, it would be difficult. Advantage with flap is we would not be needing post-operative splintage. Whereas with graft, it looks seamless after some years, but adequate post-op splintage and physiotherapy would be mandatory for the patient.
Are you aware of any visual criteria for a youthful neck, which the flap is unable to give while a graft will give?
Sir?
Are you aware of any visual criteria for a youthful neck, which a skin graft can provide, and a flap probably will obliterate the landmarks there, which won't give? What are the things in the neck which are characteristics of a youthful neck? What defines the neck?
The jawline, the Adam's apple.
Yeah, so there are 5-6 visual criteria by Ellen Bogen. Jawline, and then you have
the mandibular border definition and a platysmal muscle tone.
That cervical mental angle should be of 90 to 110 degrees, sir.
Okay, and the sternocleidomastoid muscle gives definition.
Muscle, yes, sir.
These are obliterated by the presence of a flap. Okay, sir, that's all from my side.
Sir, time has been allotted, time is over. Now, can we move to the moderator remarks? Bajaj, sir, you want to ask any?
Bachcho, you had given very good answers. Can you tell me what is the likelihood, the age of this patient?
Sir?
Can you tell me what is the age of the patient, or patient sustained burn at what age, approximately?
The burns age could be more than a year. Or
let me put up. See the slide 2. How is the occlusion? What has happened to the mandible?
So it's not very clear to us, sir.
In slide 1 and slide 2, what is
yes,
how
sir.
your...
It's not very clear to us in the image.
Team 2?
Sir, in slide 2, the occlusion is not there, sir, because the mandible has come anteriorly.
It become dislocated. So it looks like dislocated.
Why the mandible? Why the mandible has come forward, leading to distortion?
Burns in the childhood before the ossification has happened, and because of the severe contracture, the patient would have sustained burns even before the ossification has happened. So the jaw must have come down because of that reason, because of the severe contracture process happening later.
Okay. Tell me what else you would like to see in this patient. When the patient cannot extend the neck fully, what changes you expect in the spine?
Lordosis.
Do you expect any change in the spine?
Yes, sir.
What changes are normally you expect?
Lumbar lordosis.
Lumbar.
Cervical, sir, cervical.
The neck going up to lumbar region?
No, sir.
Cervical lordosis.
Team 2?
Cervical lordosis, sir.
Is it lordosis?
Now the neck is flexed. How they can be cervical lordosis?
Kyphosis, sir. Cervical. It will be bent.
Normally, when this is happening, what changes you will expect? If suppose your neck is completely flexed, what you will do?
Bent, sir.
What you will do to
like
see?
a kyphotic feature.
So therefore, what changes you expect in cervical region, and what changes you expect in thoracic region?
Sir, you may highlight.
Now let me tell me one thing. Have you seen the lateral side of the neck on both the sides?
Yes, sir.
You have seen the lateral portion on the lateral side.
Sir.
All right. Tell me what is the normal distance between the suprasternal notch and the midline of the mandible. Normal case. आप अपनी नेक पे करके देखिए, पूरी नेक को एक्सटेंड करके. This question was asked to you. How much skin graft you are expecting?
It will be 12 to 15 centimeters, sir.
Sorry?
Please speak close to the mic, sir. Sometimes your voice is fading.
Am I clear now? Can you hear me?
Yes, sir.
What is the distance between suprasternal notch and the midline of the mandible? Both mentum is there. How much is the distance? Normal case.
12 to 15 centimeters.
How much?
12 to 15 centimeters.
12 to 15 centimeter. It means how many inches it become? 4 inches.
4 to 5 inches.
Sir, 25 to 30 centimeters.
4 to 5 inches तो भी होगा.
Sir, 25 to 30 centimeters.
Team 2.
25 to 30 centimeters, sir.
All right. What is the distance between from the mastoid of one side and mastoid of the other side, which will make the neck?
Sir?
In a normal case, the distance between mentum and the suprasternal notch, that is the vertical length of the graft which you require, graft of flap, and what's the distance between mastoid of one side and mastoid of two sides. That is the amount of graft you will require in a normal when you are operating on these cases. अरे भाई तुम तो इतना तो अपने नेक पे करके नहीं दे सकते.
Sir, mastoid to mastoid is 15 to 18 centimeters, and from mentum to the sternum it is 25 to 30 centimeters.
25 to 30 centimeters. How many inches it become? Divide by 2.54. How much it
10 to
becomes?
12.
Huh?
10 to 12. 10 to 12, sir.
तो थोड़ा जब बहुत अच्छी लंबी गर्दन हो गई. Now the distance, normal distance between this and vertical side is 8 to 9 inches. And similarly, that from one to the other side is 8 to 9 inches. That much amount of the graft of flap is required. All right. Now, in a patient like this, where you are seeing the mandible is pulled up completely down there, the whole structure is lost. So therefore, this patient will require some other procedures to be done to make the mandible in good position. So therefore, the flap is the prime requirement for these patients. Second question which was asked to you, I'm giving you the answer now. Second question which was asked to you, what is the importance of the flap and the graft? Graft is always better if you are asking for a neck, a cylinder neck. A full thickness graft, you can take this much amount of size, that will give a beautiful neck. But in this case, where the patient is young, less than 18 years of age, a flap is required, thin flap is required, so that you can further pulling of the mandible is prevented, and any surgery on the mandible to put in correct position will be done. Is it right? Can you get it, me?
Yes, sir.
Okay. Thank you. We can go for another.
Any questions from judges or senior faculty, other senior faculty?
So you asked for, you said that you will do incise and release. Your aim is aesthetic and functional result. So by incising, all the hypertrophic scars will be hanging. You might release. So will you incise and release or excise and release?
So first we would always start with an incisional release, and then
Yes, of
we would
course.
excise the hypertrophic scar which is coming.
So naturally, if you say only incise and release, that gives impression that only you will incise.
No,
Number
sir.
two is, what is intrinsic contracture and what is extrinsic contracture?
So intrinsic contracture is a contracture occurring in the area of burns which are involved.
In the area of insult.
An extrinsic contracture is the contracture around the surrounding areas. Like for example, if there is a burns in the neck which can involve the lower lip, the burns over the neck is the primary contracture, and over the lip can be a secondary contracture. I mean,
So
intrinsic
therefore,
and extrinsic.
Therefore, what is the importance of extrinsic contracture?
So usually when we release the intrinsic contractures, the extrinsic contractures are corrected by themselves. We need not release them further.
Yes. So correction of extrinsic contracture determines adequacy of the intrinsic contracture treatment. Okay?
Yes, sir.
And number three is, you see the third picture, and if you have to give a flap, is there a flap there? Is there an available tissue, local tissue?
Scapular, parascapular flap.
Oh, scapular is behind. You see that picture only. You are not seeing the scapula.
Yes,
I'm
sir.
giving you
Here,
the hint.
We have three.
Lateral arm flap or the epaulette flap.
The cervical pectoral flap, sir. Delta pectoral flap.
Deltopectoral.
No, sir.
Deltopectoral area is not free. The vessel area itself, the perforator area itself is damaged. No?
Left
Epaulette flap
supraclavicular,
or
sir.
the lateral arm flap.
Sir, left supraclavicular flap is available in this case.
You are talking region wise, but you are not taking the name of the flap.
Lateral arm, sir.
Epaulette flap or lateral arm flap.
No.
Mutter flap.
Yes.
Left
Mutter flap.
flap, sir.
Mutter's
Or
flap. That's the
Mutter
answer. Mutter's flap. Based on which vessel?
Posterior auricular and occipital arteries.
No. Team
Posterior
2?
auricular artery, sir.
No. Team 2? It is transverse cervical artery.
Transverse cervical.
Okay. And what is the lateral most limit of it? How will you decide that yes, this flap is adequate? You can have a bilateral Matter's flap if available. So what is the lateral limit of this Matter's flap?
Deltoid insertion, sir. But you can take up to deltoid insertion.
Yes, you can take up to deltoid insertion, but sometimes if you feel that these are elective surgeries, you may delay the last 4 centimeter or 5 centimeter. But usually in such a healthy area, you see the transverse cervical area is free, whole supraclavicular area is free. You can always use a Matter's flap. Dr. Venkat Ratnam?
Yes, sir. Mine is not questioning. It is advice to the exam going pages. When such a spot is kept or a photo is kept like this, the expectation from you is, in addition to the aesthetic problems, first you should say oral sphincter incompetence. Second is drooling of saliva. Third is problems in feeding. These are problems like itching, pain, etc., etc. These things should come as a flow from your mouth. Then almost you're half past. Next is first wound inspection. SARS are asking. There is a technical, a term you can tell that is not a must, but it is impressive to tell that it is graft inspection. If you say first graft inspection on the 5th day, that's all my contribution.
Yes, sir.
Any other judges or any faculty? Professor A.K. Singh?
Yeah. The second part would be about the oral competence of the person concerned. How would you restore? We have already talked about extrinsic and intrinsic contracture. What would you do about the jaw deformity, as you say? The skeletal deformity. Hello.
Hello.
Yeah. Sometimes when you don't hear a response, you doubt whether your microphone is
No,
working
sir.
or not.
There was a
No,
bad
fine.
signal in between. We could not hear. Yes, sir.
Okay. So should I repeat the question?
Yes, sir.
Yes, sir.
Yeah. What about the oral competence? Number one, what about the occlusion? Two things.
Sir, in the same procedure, we can try for application of arch bar and we can see if we can get any occlusion, how much ever we can get. Since we are anyways applying a rise tube, there wouldn't, we have to apply, keep a rise tube. There would be no issue regarding the nutrition also. But if we are not able to achieve with that, we need to get an orthopantogram and further evaluation to see what are the further procedures needed
What
for
is
the
that, Graham?
mandible?
What is that investigation?
Orthopantogram.
Pantomogram.
Yes,
Okay,
sir.
go ahead.
To see what further procedures would be needed for the mandibles.
That won't tell you, no?
We will not get any information is what that.
Team 2?
Sir, 3D face.
3D facial bones with reconstruction. We can see the mandibles completely.
What about a lateral cephalogram?
Yes, sir.
Dr.
What investigations tell you about the relative position between the upper jaw and the lower jaw? Is it 3D CT or is it?
3D CT will get
3D CT face
for the lateral X-rays.
Chalo. Okay.
Cephalometry.
Yeah, next. Cephalometry. Yeah. Okay, next.
Next, we move to the team 2, sir.
Okay, team 2.
Team 2, your first quarter is this. I would like to request Tiwari sir and Sundar Raj sir to lead the questions.
Yeah, team 2. This is for team 2.
Team
Yes,
2.
sir.
Same patient or it is different
No,
patient?
sir,
No, it's a
patient.
different patient. It's a different patient.
I do.
Bhattacharya, sir, you can give brief history.
This is 7th post-op day, post-burn day, and this happened again due to blast injury, but this was a cylinder burst, not a mass casualty, and she was managed for 3 days away from at the periphery hospital, and then referred in this condition, and then further management was continued in a tertiary care hospital.
Extensive burn, no doubt. How you assess the depth of burn? What is deep dermal burn? Just let me know. What is deep dermal burn?
So deep dermal burn is involvement of the papillary dermis.
Reticular dermis.
Papillary reticular dermis is involved, then it is deep dermal burn, sir.
And how you diagnose it clinically?
Clinically, deep dermal burn will be painless, sir. The skin hair will be pluckable, easily pluckable, and it will be leathery, sir. In
leathery, esker, waxy.
Same is
and white, sir. It will be white in color, sir.
Same is full thickness also. Say it is full thickness, exact full thickness, not involving subcutaneous tissue, just the skin, and it is deep dermal. How you will differentiate between these two clinically?
So superficial burns will be pale red in color, sir.
I'm not talking of superficial burns. I am talking of deep dermal and full thickness. Is treatment different for these two burns?
Sir, in deep dermal, there will be a leathery and blisters with all this will be there, sir. In full thickness, it will
be with blisters. You expect blisters in deep dermal burn?
No, sir. Superficial.
Superficial dermal burns, we will see the blisters, sir. In deep dermal burns, the hair will be easily applicable, white in color.
I'm not talking of superficial and deep dermal. Again, deep dermal and full thickness.
Full thickness burns will be painless, sir.
How you will differentiate between these two clinically? Team 1.
In deep dermal burns, there will be involvement of epidermis and papillary and reticular dermis. Whereas in full thickness burns,
clinically, how you differentiate? I am not asking anatomically.
Sir, there will be thrombos
in deep dermal burns, there will be.
Clinically, you cannot differentiate between deep dermal.
So clinically, in deep full thickness burns, we can see the thrombosed vessels underneath the surface.
And eschar will be seen in full thickness burns, sir. In leathery texture will be seen in deep dermal burns. And white model.
Okay. What is the treatment of deep dermal burn?
The deep dermal burns, we can do a tangential excision, whereas in full thickness.
Team 2.
Sir, in deep dermal burns, yearly excision and grafting can be done, sir.
Can you name the specific excision which is being done for deep dermal burn? There is a particular name for that?
Yes, sir.
Tangential excision, sir.
Tangential excision and?
Tangential excision, sir, and the grafting, early grafting.
Skin grafting. What is difference between tangential excision and sequential excision?
In tangential excision, we will take one layer by layer, sir, and we will see for the bleeding until we get bleeding. We will remove the layer by layer, sir, and dermis is intact in tangential excision, sir. In sequential excision, we will do it in like delayed, sir, not in same single OT. We can do it in alternate OTs, sir. Like we'll check the wound and we'll do it, sir. When we are in the
bleeding, will be more in sequential excision, sir.
Sir,
in
tangential excision.
Sir, in tangential excision, we do the excision till we see the viable dermis. Whereas in sequential excision, we do the excisions till we see the viable fat.
Sequential and tangential, they are same. Tangential is specifically used for deep dermal burns with the skin grafting. Tangential. Who introduced this tangential excision term? Who was the surgeon?
Krankovic
from
Yeah, she's right. Lady Janjakovic from
Yes, sir.
From Yugoslavia.
Czechoslovakia.
Yeah.
That's how you identify viable dermis. That this is not
Punctate
the.
bleeding will be there, sir.
Punctate bleeding.
Punctate
Team
bleeding.
2. Please, team 2
Punctate
answer
bleeding.
first.
Punctate bleeding will be there, sir.
If you are doing under tourniquet, say you are excising in limb extremity, you are doing a hand excision under tourniquet.
White
Then
dermis with fat, sir, intermittent fat. That will be the...
you can confirm it by opening the tourniquet. That is there. And usual in burns, which type of skin graft you will use?
Sir, in this case, it is highly involved, sir. Donor area is less, so I will go for allograft in this case, sir, for temporary cover. Normally, we will in our institute for extensive burns after doing tangential excision, we are doing a sandwich grafting, sir. 1:3, 3 to 5 meshed homograft. Over that, we are using skin bank skin, sir, allograft.
So here you will use homograft first. Have you got a skin bank with you?
Yes, sir. We got a skin bank in our institute, sir.
Even collagen coverage also we can try, sir. So initially for a certain period we can go with collagen coverage. Once the granulation comes, the later we can go with grafting, sir.
Coming to the homograft, what is white graft rejection? What is white graft rejection?
Team 2, team 1.
One.
The epidermis is lost, sir.
Only dermal integration will be there.
That is immunological term. That is white graft rejection. There won't be any take of graft. In which condition it is there? Say when you are using homograft, you have used the homograft from one individual, and after 15 days again you try the same homograft from same individual. There won't be any take of that graft because
the immunological system attacks the graft.
So always,
and it's
if you're
immediately
using a
lost.
homograft, it has to be from different individuals.
Different individuals. Yes, sir.
That is a white graft rejection. I am done, Dr. Sundar.
Dr. Sundar.
So, sir said that this patient is presented on the 7th day. What is the ideal time to do tangential excision? And if you are to go at 7th day, what precautions you have to take? What you should be careful about?
The tangential excision we can start from the third day, sir. 72 hours of burns we can start, sir. Even 5th day and 7th day also we can start, sir. The prior requirement should be the proper blood arrangement and OT hemostatic agents. Everything should be available, sir. Previously, that wound swabs has to be taken and should be kept ready.
Why is it recommended to do it early?
Because bacterial coagulation will be lesser in the early period. So if you delay it, the bacterial coagulation will be there. The superficial wound will become, after debridement, it will become the deep, sir.
What are the clinical signs that there might be bacterial colonization when the patient presents?
So there will be a erythema in a non-burnt area, sir. There will be in under rashes and papules in the non-burnt area and the distant
of the wound also. Maceration.
Patient will have systemic symptoms of the infection also, sir.
So if these are there, would you do tangential excision?
No, sir.
No, sir.
We won't do,
No.
sir. If symptoms of systemic infection are there, we won't do, sir.
What is the danger if there is, you said, erythema, maceration of wounds are there?
Because the local infection, we are making it into systemic infection, sir. We are allowing the bacteria to enter into the circulation, so patient will go into septic shock.
Yeah, so there is a shower of bacteremia, so therefore you won't do. In which case, what is the way to manage this patient? Because this patient has come late.
So based on the cultures, we will continue the resuscitation of the patient, sir. Along with, I will try to start nutrition, improve the nutrition of this patient, sir, as it is 1 week older. I'll try to keep as oral burns are there, I'll keep a Ryle's tube, sir. I'll start Ryle's tube feedings, high protein diet. And I'll do a conservative management with dressing, sir. And taking serial culture swabs on alternate day. And based on the cultures, I will escalate the antibiotics. And
is there any surgical manner to what form of other forms of excision do you know? where without creating a shower, you can go perhaps in a staged manner, region-wise. What is burn wound excision or epiphyseal excision?
Sir, in excision can be tangential excision or sequential excision, sir. Suprafacial excision, subfacial excision. And in subfacial excision, the muscle will be
epiphyseal excision in this patient is presented 7 days now.
Yes, sir. So I'll allow the patient to give eschar incision, sir, so that the eschar will separate by itself as it looks deep burn, sir, over the chest. So
No,
escherectomy after 14 days.
That is not epiphyseal excision. The other team, please. Is there any role for epiphyseal excision?
Yeah.
Sir, it is like a serial excision of removing only the eschar and going layer by layer to prevent dissemination of the local infection into the system.
There is no layer by layer, no? You're going down to the epiphyseal area and you're going to remove it in one unit.
Sir, not the complete total burns in a single sitting. We would address 5% in one sitting and the next in another.
What power you can use at that situation?
Sir, we can give a collagen dressing if we don't have anything, or we can.
Epiphyseal is up to the fascia. We will excise, sir. We will not remove the fascia. Fascia will be intact in epiphyseal excision. After excision, we will cover it with dermal substitute like Integra, sir, so that.
This is
allograft, or we can use allograft also, sir, for temporary cover.
Okay, back to team. What is the role of allograft? What are the different roles of homograft in a major burn?
Team 2.
Sir, it acts as temporary cover, sir, so that fluid loss will be less, and it prevents the external infection coming into the wound. So, if you have taken only very less donor area is there, sir, so we can cover it so that like we can take from same donor area, we can take repeated grafts, sir. So it gives us time, sir. It gives us time to resuscitate the patient as well as.
It acts as your best biological dressing, sir. So in the meantime, once the granulation comes, later we can go with the definitive management, sir.
It prevents temperature loss also, sir. Heat loss also from the patient.
See, when you have used it for a deep partial thickness burn, it also has a scope that some healing can happen as allograft separates. When you use it for epiphyseal excision, you have to come back and do autograft. Even in that situation, the take of homograft is an indication that my autograft is likely to take. That indication is. The third use is also to use it over the donor sites of autograft in a patient with major burns, because it is going to give cover there also. Okay, sir, I am done.
Okay, sir. Moderator comments? Bajaj, sir?
Well, now tell me what team 2 is this, eh?
Team
Tell
2.
me again very clearly what is tangential excision and where it is done.
Sir, it is done in dermal burn, sir. So where we sequentially we will remove the layer by layer of the burn tissue until we see a punctate bleeding, sir.
Both the conditions
online.
Sir, tangential excision also we do layer by layer. And sequential also do layer by layer. What is the difference in two?
Sequential in tangential burns, tangential excision, we will go only till the dermis, sir. We will not go deeper than the dermis. In sequential burns, we will do sequential excision. We will go behind the dermis, sir. We'll fat and all. We'll excise in this, and the tangential excision we will do with Humvee's knife, or
say it clearly. Say it again.
Tangential excision we will do with Humvee's knife, sir. Sequential excision.
Sequential excision.
We can do with the blade also, scalpel also, sir.
Team 1.
Sir, indications for tangential excision is deep dermal burns, mixed dermal burns, and full thickness burns, sir. In tangential excision, we have to excise till the viable dermal layer, sir.
Where we see punctate bleeding.
Any excision is done, always done up to the viable layer. I am asking what is tangential excision and what is
in sequential excision, we do the excision till we see the viable fat, sir.
Fat globules.
till you see fat globules. Which burn is this?
Full thickness burns.
Full thickness.
Full thickness burns, sir. Fat.
You do full thickness burn excision by tangential method?
No, sir.
we do
Sequential excision.
sequential excision, sir.
Sequential. What is sequential then?
Sir, sequential excision we do in full thickness burns where we see the fat. Tangential excision done in deep dermal burns where we see the viable dermis.
How you will know that this is this case sequential burn and this where you are doing tangential burn?
Sir?
In what case you will do tangential excision? In what case you will do sequential excision?
Sir, in deep dermal burns, we will do tangential excision, sir. In full thickness burns, we will do sequential excision.
How you will know that?
Sir, by appearance of the burn, sir. Full thickness burn.
What is the appearance of the burn in the full thickness burn?
Full thickness burns, it will be a leathery appearance will be there, sir, and painless it will be there. In deep dermal burns, it will be white in color, white leather in white in texture, sir. Dry, waxy, and hair will be easily pluckable in deep dermal burns.
Let me clear it out. Both of you are done partly right, partly wrong. Let me give you the correct answer. Tangential excision is done when it was started by Zanzuri in all cases of burns. You excise it up and go up to the bleeding point. Then it was corrected by Douglas Jackson that this is meant for deep dermal burns. By deep dermal, we mean that whole of the papillary dermis is burnt and then you go up to reticular dermis. This reticular dermis is histologically dead dermis, but physiologically alive because oxygenation is maintained. So therefore, in this case, they were suggesting putting down the graft without meshing it up when this was started up. When they were doing tangential excision, the moment they find there is thrombosed vessels, thrombosed veins. This is a clear indication that it's a full thickness burn. This full thickness burn is now done with a normal knife, bald purpose knife. Reason is if you go for sequential burn, keep on excising, which was done by the Britishers, their blood loss is very much because when you go for the knife, then you can see the big vessels down there and you keep on ligating or clotting it up. So therefore, this is not a good method where the blood is not available that you go for sequential excision. Sequential excision is for full thickness burn. And in that case, lot of bleeding comes up. Therefore, it's not a good choice in the country where the blood supply is restricted. Is it clear?
Yes, sir.
Now, tell me one thing, seeing these cases, where you are thinking that the deep dermal burns are there, where you are saying full thickness burns are there?
Sir, in the thighs, both thighs, lower abdomen, and part of the chest is having deep dermal burns, sir. And over the chest in the central part, I can see the full thickness burns.
How you will say full thickness burn? And what is making you to think your partial thickness, deep partial thickness burn?
Sir, because that it is appearing like there are no thrombosed vessels and it is appearing waxy in appearance is there, sir. So that I am thinking it as deep dermal burns. And the burn with
appearance is for deep dermal burn? Waxy appearance is a deep dermal burn? Appearance of deep dermal burn, again I'm giving a correct answer to you. That is called salt and pepper appearance, which you are seeing on the lateral side of the eye. Whitish, blackish in between. Appearance, salt and pepper. As you mix the salt and black pepper, you start seeing that sort of appearance. which you are seeing here on the lateral side of both thighs. While on the case of the arm and forearm, you can see what you can waxy appearance of completely a scar there. They are full thickness burns, and they should be excised with ordinary knife to prevent blood loss. Is it clear?
Yes, sir.
Now, suppose this type of burns you are going for excision. What sort of special you should have in your unit or in your OTs? Can you see the extent of burn?
Yes, sir.
What special needs you require for this type of burns for excising it up?
Sir, we need to have warmers in our OT, sir. So we should maintain the temperatures so that patient will not go into hypothermia. And we should
what to do for that? What to do for that?
Sir, we should have a warmer, sir. Warmers and
Where
blowers.
do you put on the warmer in this patient?
If we are exercising the arms, we can use the warmer for the lower limbs and till abdomen. We can use the warmer, sir. And we should maintain the OT temperature also low, sir. We should turn off the ACs.
All right. OT temperature should be high, between 30 degrees centigrade for the OT temperature minimum. Is it clear? 30 degrees centigrade. Warmer, can you put it down on the just on the back only? That's all you can do it. And the fluid which we are going to giving you, that should
warm
be
fluid, sir. Warm fluid, sir.
Warm solution down there. Okay, thank you.
Any questions from
you see both the hands? Show the picture. You see both the hands. What is the difference in the condition of both the hands? Team 2.
Right. Right hand is having a superficial burns, sir, and left hand is having deep burns, deep and full thickness burns.
What is the role of decompression for the left hand?
Left hand is having full thickness burns, sir, and looks like circumferential. So we have to do a sclerotomy in the left upper limb, sir.
It is 7 days old, as I told you, isn't it? So, how do you justify decompression? Clinically and scientifically.
It prevents further, sir, if any edema is, as we are resuscitating the patient, if edema is, fluid creep is there, so the edema will develop in the muscles, sir. So sclerotomy will prevent further damage to the muscles and the distal hand, sir.
See, in today's world, any surgical intervention, you have to take a consent from the attendant. Okay. So decompression is a surgical procedure. How will you convince the attendant that decompression will help this patient? Looking at how will you convince them? In this particular left hand, I'm talking. How will you convince them? Look at the hand.
Sir?
There will be chances of even going for ischemic changes also will be there, sir. We have to tell the patient that it may progress to ischemic changes. It may develop. The wave of sclerotomy and decompress surgery, sometimes it will prevent, and based on that we have to follow up the patient, sir, whether it's progressing or.
I'm asking you, how will you convince the attendant?
Sir, I will tell him that if you don't
and
do
yourself,
the chance of amputation will be there distally, sir. So if you do it, we can prevent it.
Team 1.
The hand is going into claw hand, sir.
And we are not able to clearly see the fourth and fifth digits, which might have already
Land up in
pre-gangrenous changes. So we need to explain the further progression, and we need to tell the chances of amputation or disarticulation which the patient might end in, and convince the patient and the attendants for the surgical procedure of decompression.
Sir, I will tell that the procedure is a painless one, and we can do it bedside, and there will not be any major blood loss.
But they are asking, why are you doing it?
Because
do
the chances
do you think that there will be some benefit, and how will you convince?
So I will compare it with the right hand, sir. I will show the patient's right hand. I will ask him to see the right hand and left hand movement, finger movements of the right hand.
Answer is, if you look at the palm, in the distal forearm, it is all dark, circumferential seems to be. In the palm, there is still, even after 7 days, you can see the color of the palm. You can see the second, third, fourth fingers seems to be viable. So you have to convince them that there is still, and you can prick that area, and if blood comes, or you can scratch that area if pain happens clinically. And then you have to convince them that, see, this seems to be still viable and decompression will certainly help. Okay, so we have to clinically see it and then decide, apart from other investigative procedures. Okay, right.
Can I ask a simple question, sir?
Yeah, please.
How do you take the excision in the abdomen and the back? Which
Sir,
equipment or
sir, we will after infiltration of the tumescent anesthesia, tumescent fluid, then we will do the excision in the abdomen, sir, as we cannot apply the tourniquet to prevent the blood.
instrument?
Sir,
Which instrument you will take excision?
if dermatome is available, I will go with dermatome, sir. Preferably dermatome. If dermatome is
You
not
should have-
available,
You should have definitely. That's all. Thank you.
Dr. Venkat?
Boss.
Okay, sir.
Give your opinion. Give your opinion.
No.
Okay, sir. Can we move to the second spotter, sir? Last spotter
Yes.
of the
Next spotter.
spotter 2. I would like to request Bhattacharya sir and AK Singh sir to lead the questions, and Bhattacharya sir brief history.
This is a 10-month-old post-electrical injury deformity, again treated at the periphery, and the patient is having difficulty in using the hand. There is functional disability, gross functional disability. Dr. AK Singh, please.
Yeah, okay. So the patient is right in front of you. What if you get a patient fresh? What is besides the hand? What else would you look for?
sir, I will look for the elbow and shoulder, sir, and I will see for the any exit wound of the electric, as it is electrical burns. I will look for the all exit wound sites also, sir. And it is electrical burn.
And why do you want to look at the elbow and shoulder?
Arc burn, sir, because during the electrical burns, he might have arc burn, sir. So any injuries there also, I want to rule out, sir.
Okay. So you want to see also for the wound of exit also.
Yes, sir.
Into it. This seems to be a healed burn.
Yes, sir. Healed burn, sir.
Healed burn. So what is the deformity which the patient is having, let's say, on the left hand first?
Left hand patient is having claw hand, sir. Ulnar claw hand. Looks like ulnar burn claw hand, sir.
What makes you say only ulnar claw hand? What is the position of the index and the middle finger?
The thumb is not completely involved, sir, and
agreed.
And left index finger is also not completely clawed, sir. It is partially clawed, so that's why I told ulnar, sir.
Okay. So, do you think that this clawing is because of some sort of a nerve injury, or is it the sequelae of burn itself?
Sir, it looks like
nerve related.
Because it is on the site of the ulnar side, sir. The left hand, it is having the scar is there over the ulnar side, sir. So nerve might be injured in this case, sir.
Mostly, if we can make it out from the picture, it looks like it's a central scar more over the median area rather than the ulnar area, isn't it?
Yes, sir.
Ulnar area actually, yeah, maybe extending to that side. We are not very clear about it. But what do you think is the pathology for this ulnar claw? Is it the ulnar nerve lesion?
Maybe, sir, post-burn, it may be because of post-burn sequelae, sir. So
what sort of sequelae? What sort of sequelae? That is what it. Of course, it is post-burn sequelae.
Sir, because it is managed at the periphery, so they might not have done good splinting after the, and they might not. There is proof that they have not done any flap cover, sir, immediate flap cover after excision.
Flap cover at what area? What area?
At the entry wound, sir. At the entry wound, at the wrist area, sir.
At the wrist area.
Yes, sir.
So, do you think that a flap cover would have obviated this deformity? Is it due to skin? In a flap cover, what would they replace? They'll replace the skin only.
If a flap cover is done, sir, usually the underlying tendons will not adhere to the scar, sir, and it will the deformity can be prevented, because here it is they have not done any flap cover, so the scar the tendons will be adhered to the scar and it will pull it, sir, so it can cause deformity.
So do you think it is just a superficial burn only involving the skin?
No, sir. It is a deep burn, sir, involving.
So
electrical burns. It's a deep burn. Sir.
So electric burn is a deep burn, so it would be involving also?
Also tendons and tendons also. Sir.
Only tendon?
Tendon, nerves, nerves and
nerves,
vessels.
muscles, sir. Muscles also, sir. And vessels
So
also.
how would you come to know whether only the tendon is involved or also the nerve is involved?
If nerve is involved, patient will have loss of sensation also, sir, over the area. And if a tendon is there, there will be flickering movement all can be there, sir. Nerve is involved, that minimal no movement will be there.
So do you attribute this clawing to the skin involvement or involvement of the nerve as well and the tendon?
Involvement of nerve, sir.
Nerve as well.
Because in case of electrical injury, the obvious involvement could be of nerve, sir. That then may result in deformity, sir.
Okay. So what would you do about it now? The patient has come, say, 3 months after the injury. When the wound has healed.
I'll try to do nerve conduction study, sir, first.
10 months. Okay. They mentioned it 10 months. Right.
I'll do a nerve conduction study, sir, first. Hello, sir.
Okay.
I will do nerve conduction study, sir, to see the nerve involvement.
Which nerve?
Ulnar nerve as well as median nerve also.
As well as
Okay.
HRESG ultrasound has to be done, sir.
What has to be done? I'm sorry.
High resolution ultrasound, sir, can be done.
To see what?
So to check for the nerve continuity and for the tendon intactness, we can check, sir.
Can you not check the tendon continuity clinically?
Yes, sir.
You can check it clinically. Suppose the tendon is involved clinically, what will be the problem? It's a 7-month-old injury or 10-month-old injury, and suppose the tendon, which most likely would be involved, what would be the problem? How can you clinically distinguish it from that the tendon is not injured or is injured?
Sir, when we move the finger, the tendon, we can palpate the tendon movement at the wrist joint, sir, by moving the passive movement of the fingers. We can see the movement of the tendon at the wrist joint, sir.
Deep to this scar?
And
okay, what would you do for this patient? We have come to understand that all the 3 structures, the skin, the nerves, and the tendons may be involved in electrical burn. So how would you proceed to manage this patient? And it is 9-month-old patient or 7-month-old patient.
Sir, first I will do the basic investigations for the patient, sir. And then I will do nerve conduction studies as well as I will do MRI of the wrist, sir.
Bilateral upper limb,
sir. Then I will explain the patient that even after surgery, the recovery may not be complete. I will inform the patient, sir, because if there is a tendon shortening is there, as it is 1 year old, I'll tell him complete recovery may not be there. And if it is nerve injury also, I'll tell the patient about the
chances of nerve graft.
I will explain the patient, sir. And I will tell the patient about intraoperative after excision of the scar. If the defect is there, I will plan for a flap cover also. I will explain to the patient, sir.
Okay. So first of all, coming to the flap, which flap would you like
Parambilical flap. Parambilical flap we can be used for this case, sir.
Parambilical, pedicle flap or free flap?
In our institute, we do pedicle flap, sir, for these cases. Pedicle flap, sir. I will do pedicle flap because it is electrical burns. I don't know the status of the vessels, sir. Whether I prefer pedicle flap, sir, in this case.
And that too, parambilical? Okay, let me ask you a leading question. Why not the traditional groin flap if you are doing a pedicle flap? What is the advantage of this para-umbilical flap versus the groin flap?
Sir, maintaining of the position is easy in para-umbilical flap when compared to groin flap, sir.
What type of skin does it provide? What is the difference in the texture and thickness of skin at both the places?
Para-umbilical flap will have a thicker. It will be thicker than the groin flap. And that it looks like a child, sir. So the para-umbilical flap will give some thick flap than the groin flap in this case, sir.
It looks like a child. What do you base it on? Why do you say the patient looks like a child? Sir has said. Okay. Fine. If he has given the age. Okay. So in the first stage, you will like to do only what? Excision of the scar? What will be your whole procedure?
In first stage, I will do excision of the scar, sir. Then tenolysis, if tenolysis of
whatever
the tendons.
addition is there, we have to clear it off, sir. First, addition has to be done. Then the nerves, we have to get it free, sir. Then neurolysis has to be done, sir.
Then followed by flap cover, sir. Scar excision, tenolysis, neurolysis, followed by flap cover, sir. In this case.
Okay. So do you think that the tendon is only adherent to it, or there would be a loss of tendon because of the electrical burn?
There can be loss of tendon due to electrical burns also, sir. If tendon loss is there, sir, I will go for tendon grafting.
And what about the nerve?
Nerve injury is there, sir, nerve grafting, sir, because...
So all these things we like to do in the single stage?
Stepwise, sir, I will try to do in stepwise manner. First step, I will excite the scar, and I will try to do tenolysis and identification of the nerve, and try to do nerve grafting. Then flap cover. Then secondary procedure can be plan later on, sir, based on the improvement of the patient.
Okay. When you are doing a tenolysis, of course, would you put a tendon graft also? Because obviously there is a loss of tendon.
No, sir, tenolysis, we will do it in secondary stage, sir. First time only we will do tendon repair and nerve repair in secondary stage, sir. First we will do tenolysis and neurolysis, and we will do flap cover, sir. Tendon grafting and nerve grafting will be done in secondary stages, sir.
But why don't you do it in the single stage as you mentioned earlier? Patient would like to have all the things done in a single stage. That would be the wish of any patient. Everything should have its pros and cons. So if you want to stage that procedure, there must be some reason behind it. If you don't want to do it in one stage, that also has some valid reason for not doing it in one stage. Otherwise,
there will be a neurolysis. So there will be neuroma will be there, sir, the nerve ending.
So you do it primarily after 9 months, there will be neuroma. If you do it secondarily after the flap you have done as the next part of surgery, even then you'll find a neuroma.
Sir, after tenolysis, when we do the physiotherapy, there can be stretching of the tendons can be there, sir. So that, and when we do all in the single setting, there will be development of edema also, sir. So,
sir, one thing is we need a stable skin cover and supple joints before we go for any tendon repair, I mean for the nerve repair. And if we give the flap cover and do it, a post-operative physiotherapy is also difficult for the patient. So we need to stage the procedure by giving a stable cover first, and then we need to address the tendon and the nerve repairs in the second stage.
Tell me one thing, question, back to team 2.
Sir.
Whenever you do a nerve repair or tendon repair, do you want that wound should be closed on all sides or it should remain open And communicating to the exterior as you are doing in a pedicle flap.
It should be closed on all sides, sir, when we do the nerve and tendon repair.
So you got the answer?
Yes, sir.
So, okay. If you have done the flap repair in the first stage, how long would you wait for the second stage?
3 months, sir, minimum 3 months.
Minimum 3 months. Okay, fine enough. No. Dr. Bhattacharya, you'd like to take over?
You see both the hands, the thinner eminence of the right side and thinner eminence of the left side. Okay, so there is hypoplasticity on the right side, isn't it?
Yes, sir.
How do you explain it? On right side, there is hypoplasticity. On left side, it seems to be okay.
So that may be because of injury to the ulnar nerve, sir, on the right side. So it causes
Which nerve?
hypo.
Specify nerve.
Could be median nerve also, sir.
Median nerve, sir.
Median nerve supplies. It was what type of nerve it is? Sensory, motor. Team 1.
Mixed nerve, sir. It's a mixed nerve, sir. Median nerve is
mixed nerve.
Mixed nerve.
Mixed nerve. Okay. So it supplies which muscles? Why it is hypoplastic? Name the muscles.
It supplies the hypothenar muscles, sir.
Name the muscles.
Sir, it is
I think the question is for the median nerve.
Median nerve.
Sir, it supplies the flexor digitorum superficialis flexor digitorum profundus, sir, and it will enter the carpal tunnel, and it gives also supply the appeta digiti minimi, flexor digiti minimi,
and opponent digiti minimi.
Oh, the median nerve.
Team 1.
The first and second lumbricals.
Abductor pollicis of the abductor pollicis, sir, and opponent pollicis, flexor pollicis brevis.
Flexor pollicis longus, sir.
And first and second
First and
lumbricals.
second lumbricals.
In this, which hand will you operate both hands simultaneously? Both are having deformity.
No, sir.
No,
So
sir.
first should be right hand should be operated, sir. Single hand we should
Why?
operate, sir.
Why?
Based on the
dominant hand.
patient's
Dominance.
requirement, hand dominance.
So you'll have to ask the patient.
Yes, sir.
You have to ask the patient. So suppose you have given a flap and you said after 3 months you will go in and operate. So the flap is there. So how will you expose the nerve and tendon? Flap is inset all around.
So,
How will you explore?
incision should be given from the middle of the flaps and not from the periphery.
Why not from one periphery? Half circumference?
Because the flap gets blood supply from the periphery, sir. So after flap.
So you have given adequate time of 3 months, you said.
And there will be scar at the periphery, sir, because of flap adherence. So we may injure it, sir, while dissecting it when we take it from the periphery.
Team 1.
Sir, if we are taking the incision less than 50% of the circumference of the inset, we can raise even from the margins.
The answer is it will be through the flap from the center, maybe in a laziest manner, because then you will have more exposure. You can undermine the flap on either side. If you do only hemicircumference, then you may not have full approach to the tendons and nerves, because it's most of the time it is unpredictable. So if you don't get exposure, you do further incision and then you lose your flap.
Yes, sir.
Okay. So it gives better exposure. Okay. Now, once you have made an incision, suppose, then in second stage, what you are going to do in third stage? How you are dealing with the tendons and nerves? What you are expecting?
In second stage, we will do nerve grafting, sir. If anything, nerve injury is a nerve grafting. And in stage 3, tendon grafting.
The second stage,
Then?
we could go for a nerve graft only, sir.
Nerve graft, sir. First, we'll prefer nerve graft, sir. And
why not tendon and nerve together?
Because position is different for tendon and nerve, sir. Nerve, we cannot stretch the nerve when we do nerve graft.
What is the difference in the position of but this right hand if you do a nerve graft and if you do a tendon graft? What will be the post-up position you will require?
If we do a tendon graft, sir, the patient has to be position has to be kept in a wrist in 60 to 70 degree extension, MCP set 90 degree flexion, and IP joints in extension, sir. So the nerve will be stretched in that position.
Okay. So during the nerve repair or nerve graft, will you do anything to the tendon?
Tenolysis we can do, sir. If adhesion is there, we can go for
anything more than tenolysis?
Tagging them.
Tagging of the tendons.
Tagging of the tendon also we can do, sir.
Suppose you are doing tenolysis means there is continuity of tendon.
Yes, sir. If
okay.
a cut tendons are there,
but
sir,
still it is shortened. So can you add anything to tenolysis so that you get more benefit?
We can go for tendon lengthening, sir, with Z-plasty we can do.
Less than that?
Splitting.
Z-plasty proximal and put it.
Can you do anything at the musculotendinous junction?
Release.
Release.
We can exercise and we can switch it like L, sir. We can extend
you will not exercise. The team 1?
Half L, 7.
Partial release at the muscular tendinous junction.
What is that called? Partial release means what? It doesn't mean anything.
Partial release.
What do you do in the musculotendinous junction to lengthen the tendon?
Z-plasty.
No.
We'll cut it like L shape, sir, so that we can lengthen it.
You are talking Z, you are talking L, but you are not talking of anything else. That is also an alphabet. It is VY advancement. Okay. So that is very effective. If there is a shortening of, say, about 1.5 to 2 centimeter, that will take care anywhere in the body.
Yes, sir.
Okay.
Yes,
right. Dr. Venkatatnam?
Bajaj sir.
Again,
Bajaj sir. Okay, sorry. Bajaj sir.
Well done. Tell me one thing. In this hand, we have been towards electrical burn. There are no burns on the finger. How these people have sustained burns, which is involving only the volar aspect of the forearm and wrist.
Sir, because at the bridge joint, the bone is there and tendons are there, sir, which will have less.
So it has in compact space, sir.
So it provides high resistance, sir. High resistance is there at the bridge joint when compared to the fingers or forearm, sir.
He is asking predictable mode of injury where only both the wrists are involved.
Sir, the child have met caught the cable.
No, I asked the question. There are no burns on the fingers. There are no burns on the fingers. The burns only on wrist and the flexor aspect of the forearm. How this can happen in electrical burn?
Sir, palm also is there, sir. It might have healed, sir.
Finger.
Say it again, beta.
Sir, might have holded some material with the palm, sir.
Holding in the palm.
Heater, sir, water heater.
All right, let me put down another. What is the burns in flexion and burns in extension?
When patient is holding something and it is in flexion, sir. The hand.
Patient is holding, then there will be burns on the hand. There are no burns on the hand.
Extension, burns in extension is protection, sir, for hand. When mixed flame burns or something happens, patient protects with the hands, so it causes burns over the extensor aspect, sir.
This fall. All right. Tell me why there is ulnar deviation in both the cases. The ulnar deviation of the wrist.
Sir, for right hand, it can be because of the scars. Left hand, it can be because of the scars, sir.
All right.
We have
Then for the right hand?
Right hand. Right hand median nerve injury, sir.
The median nerve injury will lead to the ulnar deviation.
Radial artery, radial nerve also injury, sir. Median radial injury.
Which injury?
Radial nerve injury, sir, on the right hand.
Radial nerve injury will lead to the ulnar deviation of the hand.
Sir, upper radials.
Can you give me two different types of electrical burns which takes place in AC current?
Sir, in AC current, there will be alternate, sir. So it will cause muscle fasciculations, and patient will hold the, if he's touching the cable, he will hold it for a long time, sir, because of the muscle. He cannot leave it off, so it will cause more damage, sir. AC current.
Leaving will come only when the fingers are involved. So therefore, if the flexor aspect burns are there, then the child will keep on holding. The flexor muscles will go in spasm and you tightly hold. So when you fall and that extensor muscles go in spasm and you are thrown away from the electric current. Now in this case, what is happening?
DC current, sir. It might be because of DC current, so high voltage. So patient might have thrown away from the.
अरे भाई कोई जादू है हाई वोल्टेज करंट आपके रिस्ट पे ही लगा दोनों रिस्ट के ऊपर पाम पे नहीं है ऊपर नहीं है नीचे नहीं है कहीं एक जगह पर ही लगा बर्न और वो भी दोनों हाथ के अंदर ये मैजिक
Would you follow what he commented?
No, sir.
I'm asking you, have you seen electrical burn?
Yes, sir.
Yes, sir.
All electrical burn, hand is involved in 99%. Now, in this case, we are seeing injury which is confined to the wrist. And that too only flexor aspect.
Sir, maybe of some other person might have
Now on the right hand you are seeing completely hole-like appearance in the lower third of the forearm. While on the left hand side you are seeing the scar. And both are leading to the ulnar deviation.
You might be holding something with the hand, sir. So that might have got from playing toy or something.
You hold with the hand, you have to burns on the hand first.
He's holding ball like.
The only possibility remains that they are touching to the wrist. That a condition will remain that you fall on a wire. No other condition will lead to this type of the burn.
Sir,
Okay.
I will solve this problem by telling the history actually. See,
Yes.
these boys were playing and they were holding a bucket like this, and the wire was a wide wire was hanging in between. So they were surrounding the where they were holding the bucket, and one of their friend, he switched it on. So suddenly the wire had current, and therefore both the bowler sides got damaged. So that's the part of the game they had, and somebody
All
switched
right.
on it.
All right. In that condition,
That explains why the bowler aspect, typically almost mirror image area, is damaged.
you should have given this history. All right, now you got the history, it's so much better. So therefore, now what type of the burns are there? The high voltage burn, low voltage burn, high tension injury, what type of injury is it?
Sir? Get, sir. I didn't get you, sir.
Now, is it a high voltage burn, low voltage burn, high tension injury? What type of injury is this?
High voltage, sir. It is a high voltage injury only, sir, because it is involving.
बेटा अभी तो आपको हिस्ट्री में उन्होंने बताया the children holding a bucket and bucket they are put on some wire. The wire must be a household burn. Household. How they can be high tension? The normal domestic voltage. And that is the reason that you are not seeing burns in the upper part of the forearm. They are confined to that. Burns happen only locally. So what damage you expect in these cases?
Okay, sir.
What damage you are expecting in the left and the right?
Left tendon injury along with the ulnar nerve injury. So left hand we are suspecting tendon injury and ulnar nerve injury, sir. Right hand we are suspecting median nerve injury and tendon injury.
Why only ulnar nerve you're thinking? Why not ulnar artery?
Ulnar artery also can be injured, sir.
On the left hand. Is it
Left
right?
hand.
The first to go will be ulnar artery, ulnar vein, and then the nerve will come afterward. Wet surface is the best conductor of the current. Is it right?
Yes, sir.
And that in the case of the nerve, the immediately damage, they do not move the current from that place, only damage done locally. Okay, then what is happening on the right side?
Sir, we couldn't get you, sir. Sorry, sir.
Yeah. What damage you expecting on the right hand?
Median nerve and tendon injury.
Sir, could be of a median nerve injury as well as tendon, sir. Tendon, since it's a ulnar deviated, so maybe of a FCR might have damage, sir.
Because you are seeing the claw hand. Therefore, ulnar nerve तो पक्की गई है उसके अंदर. जो ulnar nerve जाती है, तो इधर से adductor pollicis भी चली जाती है, तो वहां भी आपको thinning मिल सकती है कि ulnar nerve के अंदर. Adductor pollicis is also supplied by the
Sir, they may not be understanding Hindi. Please speak in English.
I said you are seeing the ulnar deviation. It means ulnar nerve is likely to go. You are seeing the claw hand. It again confirms ulnar nerve injury. You are seeing comparatively less injury on the index finger. So therefore, they are unlikely the median nerve injury will be injured. You are seeing the thinning in the hypothenar area. This thinning could be because of the paralysis of the adductor pollicis. Adductor pollicis is also supplied by the ulnar nerve. Rest all muscles are supplied by the median nerve. So this will tell you all the likelihood of the injury. Better you can see to it. Team 1, you are getting the point?
Yes, sir.
Is it clear, or you have got something you want to say in this?
Understood,
Right.
sir.
No, yes, you want to say something? Tell me.
No, sir.
Now you will ask about wire flap and other things. What you will do first in these cases? You got the injury pattern and all other things. Why you will go for the flap first?
Sir, it flap all like crane principle, sir, because of one is crane principle. So it will.
First of all, you will try to find the what the defect is there, what things have gone. Once you have corrected down there, there might be possibility of some local flap. You can put it down and close it immediately. Lot of local flaps, you can do it. The first thing requirement is you go and find where the damage is there and correct all the damage. And then you can arrange local flaps. Lot of local flaps can be arranged for this, only for that reason. Okay, both the teams have not given correct answers. Anyway, but you replied quite nicely. Thank you.
Thank you, sir.
Thank you, sir.
When you bring the defect to the flap at a distant area, what do you call this procedure?
Transfer of the flap by the surgeon's hand, sir.
No.
Surgeon's.
When the defect is brought to the flap at a distance, what is it called? Number
Passive
one.
transfer by the wrists.
No,
passive.
just one terminology.
Indirect,
classification.
Sir. Indirect transfer, sir.
Indirect transfer. Played team one. How do you classify this nomenclature?
Direct and
Defect
indirect
what?
two ways.
What do you mean by direct and indirect?
Defect
What is
coming to
indirect?
the flap.
So direct is flap coming to the defect.
Flap
There it
coming
is
to the defect.
flap. Defect is coming to the flap. So here.
Okay. And what is indirect?
Flap coming to the defect
side.
Flap coming to the defect. What is the difference?
Defect comes to the flap.
Flap and flap coming to the
flap
defect.
is called as indirect. It's coming. Hand is coming close to the groin. It is indirect.
Okay, I'll answer it. What is indirect? You mentioned also direct means there has to be an indirect. Basic, absolutely basic, zero basic.
Sorry.
Indirect is transferred by the opposite wrist.
Why opposite wrist? No.
Surgeon wrist, sir. Transfer.
Okay. When you bring the defect to a distant area, it is called direct distant flap. As simple as that. When you transfer a flap to a distant area, say you want to transfer abdominal flap to leg defect, then you have to make a tube pedicle, and then you attach that one end of tube to the wrist, any wrist, according to the convenience of the patient. Okay.
Yes, sir.
And then
Yes,
you
sir.
detach it, and then it is transferred to a distant area. So it is indirect through wrist. You are taking help of the wrist. Okay.
Yes, sir.
So what is an axial flap and what is a non-axial flap?
Axial flap will have a known blood supply, sir. The flap will have a blood supply.
What is a peninsular flap? Okay. Any other person wants to mention anything? The Dr. Venkat?
Sir, I cannot hold back. I have to leave now. I want to tell.
That's why I caught you. That's why I caught you.
Thank you. I was trying a private message. I was not able to open it. Sir, I don't want to waste time. Just one word going. In a couple of words, probably. Somebody was telling in the infected case, they can use collagen. I think team B is telling. So
we didn't tell, sir. We did not tell collagen, sir. We told about homograph.
Maybe team A.
No, sir, not in infected cases.
Everybody would deny.
The point is
leading questions.
The infecting organisms will eat away the collagen. it will not work until you clear the infection. Collagen, no role. The next thing is probably last thing from me today is when seniors are talking, when teachers are talking, listen. You are trying to show that you know the answer. First, let them complete. There is a lot of learning. You will not learn them by reading books. It is coming from the years of experience from the teachers. So first listen. Everybody is talking. Maybe as if to win the prize. It's not like that. When somebody is telling listen, sometimes even a question you will have to ask again and listen completely, understand their answer. These are the things for the examination purpose sake I wanted to tell. And I'm sorry I have to take leave of you all. Thank you very much, everybody.
But
thanks
before you leave, as a patron of Plastiquest, let me express my sincere acknowledgement for your generous attitude of sponsoring all these programs for the benefit of the future of plastic surgeons of India. It's a great, generous gesture on your part, and we sincerely, from the bottom of heart, we acknowledge your contribution, scientific contributions for sponsoring everything, and to show your large-heartedness. Thank you so much for this.
Thank you.
Thank you.
Thank you very much.
I have to answer for that, reply for that. I have been telling that it is. I did not want to come onto the stage. Dr. Lakshmi did not leave me. Without telling that I am the sponsor. Why I did is different, not for that sake. No offense, Dr. Lakshmi. Why I did this is the excellent program is coming. As I have been just telling now, very many seniors, examiners, all over the country, they are coming and sharing their knowledge. So such a program had come to a dying stage because of certain time limitations as well as number limitations, participants number limitations. So at that stage, I could not tolerate, I could not take it. So this is what I could do. I did it from my side. Okay, Dr. Lakshmi made it. Anyway, thank you all for sharing your knowledge. I learned a lot. I am learning a lot. Each session today. Thank you very much.
Thanks a lot to you.
Thank you,
Thank
sir.
you very much, sir.
Thank you, sir.